Thank you. Amputation is a radical and irreversible intervention. Indications must be determined by surgeons with great surgical experience and good knowledge of military or disaster surgical doctrine. Unfortunately, it's rarely the case. Only few surgeons have this experience. In fact, some volunteer surgeons may be interested in providing care for civilian victims of war or disaster in developing countries. However, there are significant differences between the type and the management of cases seen in this context versus those seen at home. The goal of this presentation is to provide a brief overview of the principal and practical aspects of surgical response to limb wounded in natural disaster. I am a military surgeon in the Percy Academic Trauma Center in Paris. I teach orthopedic war surgery in the department created by Baron Dominique Larrey, Napoleon's famous surgeon. Our French Army Medical Service is currently engaged in treating servicemen or civilians injured in armed conflict and in catastrophic natural disasters. In my opinion, strategies for the surgical treatment of wounds are different in military and disaster relief situations. However, there are plenty of common principles for this true practice. Only a good knowledge of the two situations allows us to take the right decision. The problem of amputation cannot be solved schematically. The decision to amputate in normal practice is always difficult. It's all the more difficult when a surgeon is removed from his normal environment and familiar routines and injected into a crisis situation. Amputation will depend on several factors: the form of disaster, the conditions for surgery, the skill of surgical team and the experience of the surgeon, the duration of the mission. At the same time, this context demands a higher level of excellence because one is treating a fragile population in a vulnerable state. I suggest that we reflect on both the ethical and practical preparation needed for an orthopedic surgeon. We are going to prepare him to make rational choices and have practical strategies under crisis situation. Here is a schematic showing the two main situations I have seen in my own experience: war practice and natural disaster. These two different situations require different strategies for making amputation decisions. In war practice, for servicemen, evacuation is often quick. Only one surgeon is available, working in field hospital with limited resources. The wounded are rapidly air evacuated to an hospital in developing countries. For example, a French soldier wounded in Afghanistan will be in my hospital in Paris in 24 hours. In case of natural disaster, there are many wounded civilians who arrive at the medical facility late. There is no professional evacuation, and there is usually only one surgeon in a single limited medical facility to provide all treatment. The surgeon, in an austere environment with very little equipment, limited communication, and few resources, is confronted with unusual injuries at an advanced stages, especially with regard to infection. He must assume his complete responsibility from the reception of the patient until his rehabilitation. Sometimes the local medical facilities, often destroyed, do not allow the surgeon to provide the full treatment that conservative medical practice would normally require. The surgeon must define treatment priorities when faced with a large number of wounded civilians. He must make quick, wise choices in order to save limited blood supplies and the use of surgical procedure. I suggest continuing this presentation with the following plan. We are questioning Why amputate when our technical and surgical abilities allow the surgeon to keep the limb? How to perform amputations under these conditions? How to pass on a doctrine to the voluntary surgeons who lack experience in the field? Amputation is a frequent and essential procedure in the disaster context, and one of the standard means to successful treatment of limb wounds. This treatment has priority: save life, save limb, save function. Amputation finds its place in this schema. Amputation is necessary because saving the limb is impossible under the difficult conditions, especially for grave injuries. Saving the life can require the loss of a limb. The most difficult choice is when retaining the limb is possible, but where amputation actually allows the surgeon to preserve the patient's capability. The mass casualty situation explains why amputation is so frequent in disaster context. Finally, the requirement to treat many serious wounded quickly and with limited resources can lead the surgeon to necessarily perform amputations that are done much more quicker than the limb salvage. First of all, the situation is simple. To save the life, amputation is retained for general reasons that involve the life of the wounded. In a hemodynamically unstable patient, the amputations may be necessary to save his life. In this situation, saving the patient's life always takes priority over saving the limb. The amputation becomes a form of damage control. The amputation is compared with complex reconstructions, with a high incidence of contamination with resistant bacteria. When a patient has had an infection, the risk of recurrent infection and sepsis is far lower when the limb is removed than when it is retained. Conservation of the limb may be technically possible. The questions are: could the patient and his family afford the multiple operations? Could they afford the time necessary to save the limb? Is the amputation the best solution? For some injuries, the patient does not want to endure prolonged salvage attempts. An amputation is a viable alternative. The mass casualty situations involve the most important change in the professional mindset of the surgeon. He must know in advance this situation in order to be prepared. It's necessary for him to understand the reason and the choice of the amputation in these circumstances. The amputation is a faster, safe procedure. The logic follower must be to do the best for the most and not everything for everyone. How to perform amputations? Standardizing surgical approaches to amputation is challenging. A disaster situation requires that one adapts the behavior normally proposed in war. In the military context, the current rule is the most conservative amputation carried out in viable tissue. Final level of amputation and definitive treatment occurs after evacuation in a stable environment, not in the combat zone hospital. For the humanitarian surgical organization during war, amputation is done in safe area but left open. This requires a second look in the operating room for delayed primary closure. In a disaster situation, the techniques required is dictated by the need to maximize the use of the operating room. The initial procedure should be as decisive as possible. Debridement should be performed in healthy tissue to eliminate the need for additional trimming later. It's an amputation semi-definitive, but left open for a second procedure that will complete the operation. If this principle should be retained in this context, it's necessary to avoid a too dogmatic attitude and to be adaptable to each unique situation. The goals are to achieve amputation at the shortest possible time with minimal surgical procedures, avoiding infectious complications. But open circular amputation, called also guillotine amputation, should not be performed. I describe it as sacrificing length, which makes prosthetic fighting more difficult. It's no significantly quicker than an amputation excising non-viable tissue and foreign material if flaps are not fashioned during the primary amputation. Two options are acceptable. A definitive amputation in area of totally healthy tissue resulting in a closed stump, but the result of this amputation is at a more proximal location. A gesture in two stages, a distal incision in healthy tissue and the creation of the stump after 4 or 5 days. Excuse me. How to pass on a doctrine? Why we must communicate this practice? For reasons of ethical, morality, and efficiency. Put in place prepare teams. Whatever the difficulty of communicating rare experiences or situations, it's essential to provide a knowledge base about the specifics of practice in disaster situations. What do we teach? Context, limited security, supplies, and staff resources available require different choices in order to provide the greatest good for the greatest number. The clear strategy of amputation is imposed by the severity of injury, but also above the context. And finally, the techniques of amputation. How we teach this practice? This is the greatest challenge because there is no practical field training. We must build the training around 3 axes: feedback that highlights the need for adaptability, a theoretical focus on standardized recommendation, and surgical practice in the laboratory of dissection. A robust educational program is a fundamental component of the military treatment facilities. An accredited teaching program exists within medical teaching facilities in nearly all surgeons. Cashier makes surgical capacity in operation. Surgeons, military or civilian, sent on military or humanitarian missions must complete 5 training modules in 18-month period. Each module lasts 3 days. 2 modules are specifically dedicated to the subject of this session. Feedback is usually organized around a military experience and a civilian mission. Presentation of the context in module number 1 was made with a presentation of the material available for a surgical project and the opportunity to visit one. The lecture on strategy and tactics theories must be done in anatomy laboratory with a ratio of one professor for 2 students. In conclusion, deciding to perform an amputation is always difficult. In an atmosphere of disaster, understand the context of the particular exercise is critical to the strategic choices of non-conservation of the limb. Preparing for this eventuality is a moral obligation and a practical necessity. There is no dogma, but there are principles in indications and surgical techniques. These principles will avoid disaster for patients. Thank you.
Thank you. The next paper is Amputation in Natural Disaster.